I'm Megan Fertiber.
And I'm Chris Urbanik.
We are two primary care sports medicine physicians working out of East Carolina University in the Department of Family Medicine.
This is going to be our AFP video series on basic examination and injection techniques for the foot and ankle.
Whenever we approach a musculoskeletal examination, we do like to use the mnemonic IPASS, which stands for inspection, palpation, active-passive range of motion, strength, and special tests. We're going to go ahead and get started and talk about the first part of that mnemonic, which is inspection and palpation. So when you're first evaluating your patient who's coming into the office with concern for foot or ankle injury, of course, one of the things that you want to evaluate for is there swelling, is there bruising, is there redness any place, is there warmth any place? The next thing that you'll do, as long as your patient is able to do this for you, is you'll have your patient stand up and walk and evaluate their gait. As we inspect our patient, one of the things we want to make sure we do is evaluate their gait. A lot of times a patient's gait can actually contribute to some of their foot and ankle pain, especially if it's something that's chronic and long-standing. You also want to make sure that your patient can weight bear without too much difficulty. As your patient is evaluated walking, you want to evaluate whether or not they are pes planus or pes cavus, and you also want to see whether or not they overpronate or supinate during that gait pattern. So we just evaluated our model's gait here, and we were able to tell whether or not she is having pain in certain aspects of her gait whenever she's planting her feet. The other thing that we're able to evaluate is whether or not she has flat feet, which we like to call pes planus, or if she has a little bit more of a curve into her longitudinal arch, which is called pes cavus. We also evaluate for overpronation and supination of the foot, which is something that you can see very easily by watching somebody walk and watching somebody weight bear. Next, we're going to move on to the palpation aspect of our examination. And I'd like to first start up here at the head of the fibula. Whenever you're evaluating your patient with a foot and ankle injury, one of the first things that you want to do is you want to make sure that you palpate the head of the fibula. This is a common site for small little stress fractures and injuries, especially with folks who have had acute injuries to their ankle. What I then do is I work my way down the leg. So I'll start palpating out through the tibia and the fibula, working my way down the whole way to the ankle. As I'm going down here, I'm looking for any areas that are particularly sore or painful. As I move down closer to the ankle, I ensure that I palpate around both the lateral and medial malleoli. Important reason for this is that there are a set of rules called the Ottawa Foot and Ankle Rules, and that is a guideline as to when you should get x-rays of somebody with an acute injury. And some of the key areas where somebody is experiencing pain, if they do have something like a stress fracture or stress injury, are at the medial and lateral malleoli. I'll also work my way down, if I'm coming laterally, down through the distribution of the peroneal tendons. You do have both peroneal longus and peroneus brevis. Peroneus longus does attach the whole way down to the base of the first metatarsal. Peroneus brevis attaches down to the base of the fifth metatarsal. I'll palpate down through their attachment points, and actually right here at the base of the fifth metatarsal, it's a common area where folks can develop stress fractures and is also a common landmark that is used in the Ottawa Foot and Ankle guidelines to help guide the decision making on whether or not to get x-rays on a patient. I'll then palpate out through the tarsals, and I'll get into the tarsal cuboid to ensure that there's no pain, and then I work my way down along each of the metatarsals to ensure that I'm not finding any of those areas that are particularly painful. And then I'll ask the patient to turn, or I'll move around the patient so that I can get to the posterior aspect of the ankle and then further evaluate. Now we're going to focus on the palpation of the posterior aspect of the foot and ankle on our model. I'm going to go ahead and start talking about some of the areas that I commonly like to palpate. Coming down through the gastrocnemius muscle, palpating down through the myotendinous junction, and then to the part where the muscle becomes tendon, or the Achilles tendon, and coming into that attachment point of the distal Achilles tendon onto the calcaneus. This can be a common site for something called insertional Achilles tendinopathy, which is very common. If I squeeze on either side of that Achilles tendon, there is a retrocalcaneal bursa that's there that could develop in some patients with repetitive injury, repetitive trauma to this area. And so that's why it's always important to palpate right in here. And then as I move my way down into the plantar aspect of the foot, I do like to palpate out toward that calcaneal fat pad, or that heel fat pad. And then I'll palpate through there, and coming down into the area of the calcaneus where you have the origin of the plantar fascia, as this is commonly associated, if somebody has pain here, can be commonly associated with plantar fasciitis or fasciosis. One of the areas we want to make sure not to neglect are going to be the areas of the distributions of the most common ligaments in the ankle. Laterally in the ankle here, we've got three big common ligaments: the ATFL, the CFL, and the PTFL. Now we're going to move on to the palpation of the medial aspect of the foot and ankle. When we approach the medial aspect of the foot and ankle, we want to ensure that we palpate some key structures. One of these is the deltoid ligament, which lies here medially and is composed of multiple other smaller ligaments. We also want to ensure that we palpate down the tarsal tunnel. Now, the tarsal tunnel consists of a few key structures, including the posterior tibialis tendon, the flexor digitorum tendon, and also the flexor hallucis longus tendon.
So moving on to the next part of the examination, we're going to cover active, passive, and resistive range of motion. For the ankle, it's really quite straightforward. There's two primary axes. The first one covers both dorsiflexion, which is bringing the toes towards the nose, and plantar flexion, which is a pushing down motion. The other axis is inversion and eversion. So inversion was more of an adduction to the foot. Eversion is an abduction. And you can test those, as we've discussed previously, with active and passive motions. So actively, you can have the patient pull back on the foot. And if you want to check passive, you can apply an overpressure in the same direction. That can be repeated for the other motions that we looked at, the eversion and the inversion, as well as plantar flexion. When you test for strength, you're going to have the patient go all the way into the position, so hold dorsiflexion, resist a downward force, checking on the strength of the anterior compartments of the leg. You can again repeat this for both inversion as well as eversion, but when it comes to plantar flexion, if you push down, it's easy for the athlete to overcome the strength of my biceps with the strength of their calf. So typically people will look for other ways to meet that strength demand, and we'll do stuff like toe raises, either supported or single leg, to get a better gauge on the strength of the calf.
When you're evaluating a patient's strength, occasionally what we'll do is we'll get creative in evaluating that plantar flexion. Some patients are going to be so strong in their gastrocnemius muscles that they're going to be able to overcome any sort of force that you can generate during the examination from a seated position. So occasionally we'll get our patients up and have them perform body weight heel raises to evaluate for the strength and integrity of the plantar flexion and the muscles that allow you to do that. Now we're going to go ahead and move on to our special test for the ankle. One of the first tests I like to start with is the anterior drawer test. This test is actually evaluating the ATFL. So the way that this test is performed, you have one hand that's grabbing over top of the tibia and the fibula and stabilizing, and your other hand is wrapping around the posterior calcaneus with your thumb in the front. In sports medicine, we really like to use C's and C shapes for our examination. So this is what you want to do for this. With a good grasp on the ankle and the foot, you're going to apply an anterior force. And what you're looking for is you're looking for laxity and you're looking for clicking and shifting of the joint. Remember to always compare it to the contralateral side, especially if that contralateral side has never had an injury to it before. It can really give you a good baseline as to where the patient usually is in regards to the integrity of that joint. The next test I like to go into is a Taylor tilt test, and this test evaluates the CFL. In order to do this from this exact same position, I have a good grasp over the tibia and the fibula. My other hand, again as a C, comes around. I have my index finger just distal to the lateral malleolus to allow me to feel for any motion there whenever I'm performing the Taylor tilt evaluation. And so from here, what I'm going to do is I'm going to invert. I'm evaluating for any laxity in that distribution, and of course compared to the contralateral side. The next test I'm going to go into is called the Kliger test, or the forced external rotation test. For this test, what we're doing is we're evaluating the integrity of the AITFL ligament and the syndesmosis. So this test is very valuable for folks whenever you are suspicious for a high ankle sprain. You put the patient up into a forced dorsiflexion position, and then you forcefully evert them. What you're looking for is you're looking for reproduction of pain in this distribution, where typically folks will have injury due to a high ankle sprain. The last test is going to be the squeeze test. And this is a test that we use to evaluate folks who are suspected of having a high ankle injury. The way that this is performed is you make sure that you get a good grasp over the tibia and the fibula, usually about mid-leg here, and you apply the squeezing force. And you can actually apply this going down the leg. What you're doing whenever you're applying this force is you're working with levers. So when I apply here, I'm actually splaying out, or putting a force that's splaying out the tibia and fibula from one another, therefore putting stress on that syndesmosis that runs in between them. So if you have a positive squeeze test, that means that somebody has pain with this maneuver and likely they have some injury to their syndesmosis. Next, we're going to talk about the Thompson test, which is a test to evaluate the integrity of the Achilles tendon. So first, you want to make sure that you have your patient prone on an examination table with their foot and ankle off the edge. For demonstration purposes, we have our model here today leaning down on one of our stools with her foot and ankle hanging off the side so that we can perform the same test. In order to perform the Thompson test with the patient nice and relaxed, you're going to grab the central area of the gastrocnemius and you're actually going to squeeze. What you're looking for here is you're looking for this little bit of plantar flexion that occurs with that squeezing of the gastrocnemius. As long as you're getting that plantar flexion, if you were to perform this test and the patient weren't to have any of that plantar flexion, then you get concerned about the integrity of the Achilles, and the Achilles no longer doing its job, which means that it might be injured or ruptured.
So we're going to continue with special tests more into the foot now. The first one that we'll start with is a calcaneal squeeze test, basically wrapping your hands around the heel bone and just applying a squeeze between the two of them. What you're trying to do is elicit pain here, which may be present in instances like fractures or even Seaver's disease. We'll then move more towards the midfoot, and you can kind of define where the middle of the foot is, just proximal to the metatarsals. You stabilize both the distal and proximal ends, and then you apply a shear force between the two. This is kind of like a scouring test that you sometimes see for shoulder, hip, or wrist. You can also apply a translatory force as well, kind of going from a craniocaudal direction. The idea is that we're trying to irritate that area, and what you're looking for again is exacerbation of pain in the area, which may be from arthritis or potentially even Lees-Frank type injuries. The last one that we'll take a look at involves the metatarsal heads, and so there's a metatarsal squeeze test, whereas you get your fingers kind of over the knuckles of the toes and you're just going to squeeze them together. Pain in the area may indicate metatarsal bursitis, or in instances where you feel a palpable click, this could be Norton's neuroma. Those are our special tests for the foot. So as we finish up our video series, we're going to cover the common injections for the foot and ankle that you may see in your practice. The first one that we're going to start with is the tibiotalar or proper ankle joint injection. This can be done under landmark by both an anterior medial and an anterior lateral approach, but we're going to be showing the anterior medial as I think this one's a little bit more accessible. Again, for demonstrations, we're using a blunted 21 gauge needle, but certainly you'll go through your typical setup and standard precautions to make sure that you're appropriately addressing the patient's concerns. And so our landmark for this, and in our position, we have the patient kind of in an externally rotated hip position with the foot in as much plantar flexion as we can get out of it. That opens up the space between the tibia and the talus. We can now see our landmarks pretty easily for the injection. We have the anterior tibialis tendon running anteriorly, and so we're going to stay medial to that. We're going to be just distal to the tip of the medial malleolus, and then within that divot on the side of the ankle, you can feel the edge of the talar dome, and so we're going to come in just superior for that. You'd clean in your usual fashion, and then the placement for the needle is at about a 45-degree angle to the skin, angling both proximally as well as posteriorly. You can then advance the needle about a centimeter, aspirate to ensure that you're not intravascular, and then inject whatever injectate you may be using. The needle can then be removed, the skin cleaned and bandaged, and that's our tibiotalar injection. For our next injection, we're going to be covering the injection technique for plantar fasciitis or plantar fasciosis. And again, in this position, we have the patient externally rotated. You could do this with them side lying on the affected side to open up the medial aspect of the foot. We have to first define our landmarks for our injection. The way we do that is walk across the base of the calcaneus until we get to a divot. And that's going to tell us how far from a posterior to anterior direction we're going to be setting up for our injection. The way that we define kind of how deep we are is by looking at the natural color change of the foot. So every person has kind of this own distinct color line. That's going to be our craniocaudal dimension that we're following to set up our injection. You can then mark that with your pen. You'll clean as per how you usually do it. And then the injection is at 90 degrees to the skin, straight down, advancing about a third to 2/3 the length of the needle, aspirating to ensure that you're not intravascular, and then injecting whatever injectate you may be using. We prefer this technique as opposed to going through the plantar skin, as this keeps us deep to the plantar fascia, and so you get less spread of your injectate into the calcaneal fat pad, which if you're using steroid could cause fat necrosis or fat atrophy. For our final injection, we're going to be covering the intermetatarsal injection. This can be useful for both intermetatarsal bursitis as well as Morton's neuroma. Our setup for this position is to get the patient in a plantar flex position. You have to first find your landmarks, and so in this instance we're going to aim for the third web space or between the third and fourth digit. You can palpate the dorsal side of the metatarsal heads, mark your area, and then clean in your typical fashion. The needle approach is at about a 45-degree angle. You're aiming both somewhat plantar and posterior, and then as you go through the skin, you advance maybe a centimeter, aspirate to ensure you're not intravascular, and then inject whatever injectate you may be using. The needle can then be removed, the skin cleaned and bandaged, and that's your intermetatarsal injection.
This completes our AFP video series on the examination of the foot and ankle.
Thanks for joining us.
Stay tuned for our next video series.